Okay, so good afternoon. We will be continuing with our session of on some topics in pediatric surgery, which we left off last time. So we will be discussing today about hypospadias, a genitourinary problem. Now, hypospadias, I'm sure you would have heard, is seen in 1:300 boys. So you can see the incidence is quite common, where the urethra opens proximally and ventrally along the penile shaft. So most commonly the opening is just proximal to the glans, but it can open anywhere on the penile shaft or even on in the perineum. So it is attributed to failure of complete urethral tubularization in the fetus. That means that the urethra fails to become a complete tube up till the meatus, and the foreskin is deficient ventrally, so there is no prepuce in the ventral part, and there is a variable degree of chordee. That chordee means like the bending of the penis. A ventral curvature of the penis most apparent when the patient has a erection. So glandular hypospadias needs correction for cosmetic reasons. That means it opens in the glans just below. But more proximal anomalies, which tend to open somewhere along the middle of the penile shaft or in the perineum, these interfere with micturition and erection. Okay. So here you can see a picture of a glandular hypospadias. You can see that the penile, the meatus. The meatus is opening onto in the ventral part, and much more or less it's normal in position, and you can see that the prepuce is deficient ventrally, and there is a hood of prepuce on the dorsum. So the hypospadias note the hooded foreskin, that is the prepuce, and the ventral meatus. Now you can see that the meatus is not at the tip of the glans, but it's lying ventrally, and there is deficiency of prepuce or the foreskin in the ventral side. Now, a distal hypospadias is usually repaired before 2 years of age in 1 or 2 stages. This is a classic example of a distal hypospadias. It's distal. The opening is distal away from the perineum. So proximal varieties, that means those which open into the penile shaft or in the perineum, require complex stage procedures, maybe 2 or 3 times, operating in between intervals. Now surgery aims to achieve a terminal urethral meatus so that the boy can stand to micturate with a normal stream, can have a straight erection, and a penis that looks normal. In cases of hypospadias, it is important to remember to caution the parents about ritual circumcision, because in such infants, when reconstruction is done, the foreskin is often required. Now that is all about hypospadias. We come to some gastrointestinal atresias, beginning with the esophageal atresia. In the esophageal atresia, it presents as a blind proximal pouch with a distal tracheoesophageal fistula. This is the most common type, where the esophagus ends abruptly and it has there is no distal connection with the stomach, and many a times there is a fistula between the trachea and the esophageal pouch. I'm sorry, I've been remaining the gastrointestinal system, that is the distal esophagus. However, sometimes there can be no fistula also. So affected patients, infants, present soon after birth with drooling of saliva and cyanotic spells on attempting to feed. Now there is drooling of saliva because the saliva is swallowed by the infant. It reaches only up to the esophageal pouch, and then it refluxes back into the mouth. And cyanotic spells on attempting to feed. Why? Because what happens on attempting to feed, the feed accumulates in the esophageal pouch, it refluxes and goes into the respiratory passage, and so the patient coughs and has got a cyanotic episode. There may have been polyhydramnios due to failure of swallow of the amniotic fluid. So during the prenatal scan, that anomaly scan, you can have hydramnios. There's much more than normal amount of amniotic fluid, and this is possible because this is probably because of failure of the infant to swallow the amniotic fluid. Now the diagnosis is confirmed when a nasogastric tube goes no further than the upper esophageal pouch. On the X-ray, you will see that the nasogastric tube coils inside the esophageal pouch, and abdominal gas signifies a tracheoesophageal fistula. So, in an esophageal atresia, you are not supposed to have gas inside the rest of the GIT, but the presence of gas means that there is a fistula between the trachea and the GIT, and that's why gas from the respiratory passage escapes into the gastrointestinal system. So here you are, this is one here. You can see the red one, there's the nasal passage joining onto the trachea. You can see the blunt, that is a blind ending tube, which is the esophageal pouch. So you can see that there is a blind ending pouch here, which is the esophageal pouch, and you can see the distal esophagus, which is communicating with the trachea. So the treatment is just 1 or 2 days after birth. If there is enough length of esophageal tissue, the connection with the trachea is disconnected and closed, and these two, the proximal and distal esophagus, they are joined together. So repair is usually via, now there can be associated anomalies also, which are cardiac, renal and skeletal defects, and repair is usually by a right-sided extrapleural thoracotomy within a day or two after birth. The fistula is divided and the tracheal side is closed. The esophageal ends are then anastomosed, joined together, and post-operative complications can be anastomotic leak, stricture of the anastomosis, a recurrent fistula formation with the respiratory tract, and gastroesophageal reflux. Infants with pure esophageal atresia and with no tracheoesophageal fistula, they are best managed by a temporary gastrostomy and delayed primary repair or an esophageal replacement, which means that if they have only a pure esophageal atresia and there is no tracheoesophageal fistula, we make a small hole in the stomach, and through that we continue feeding and put in a tube, and we continue feeding the child till the child is nutritionally resuscitated and grows, and the surgery can be undertaken at a later date to join the esophagus, or to even use a conduit as a replacement, maybe a part of the colon or jejunum, and use it as a conduit replacement for the esophageal tube. So except for very low birth weight babies and those with major congenital heart disease, most infants with repaired esophageal atresia, they usually fare well. They have a good prognosis. Small intestinal atresia. So duodenal atresia may take the form of a membrane, that is, there is a thin membrane that separates the parts of the duodenum and that causes obstruction, or there is a proximal and distal duodenum may be completely separated, just like the esophageal pouch that you saw. They can be two blind ending tubular structures. Now prenatal ultrasound finds a double bubble in the fetal abdomen with polyhydramnios. Now this double bubble is not X-ray in the mother, but it is a double bubble in the fetal abdomen. When you do ultrasound, and there is polyhydramnios, similar in the case of esophageal atresia, because of failure to swallow of this amniotic fluid. Now this problem is common also in Down syndrome, and there may be, once you see this intestinal atresia and polyhydramnios, you may be alerted to think about the possibility of Down syndrome, so that genetic studies can be done. Now postnatally, there is a bilious vomiting if the atresia is distal to the ampulla. So if the duodenal atresia is beyond the second part of the duodenum, that is beyond the opening of the bile duct, then the patient will vomit bile. But if it is proximal to that, the patient will have clear vomitus. Now plain abdominal X-ray shows a double bubble. Repair is by duodenostomy, that is the two blind ending pouches of the duodenum, they are anastomosed together, or if there is a membrane in between, that membrane is disconnected, is incised, which is also called as the windsock deformity. Occasionally there is a duodenal membrane with a modest central perforation, which may delay symptoms until later childhood. Now sometimes what happens, there is a membrane which separates these two parts of the duodenum, and there is a small central perforation which allows feeding to pass, liquid feed to pass, and this will delay the symptoms until later in childhood when the patient begins to eat solid food. Now here is an X-ray picture, neonatal abdominal X-ray, showing the double bubble of the duodenal atresia. One you can see is the gastric air shadow. Another one is the one on the right side is the duodenal loop, which is closed. So here you are on the other side, you have this, you can see that there is a stricture between the parts of the duodenum. It can be a stricture, it can be a membrane, it can be that these parts of the duodenum are totally separated also. So how they are joined together, you can see the incisions that are being placed there. Incisions are being given and they are joined together. So you are joining the duodenum to duodenum, and it is called a duodenostomy. That yellow part, which it looks like a fatty tissue, that one is nothing but the pancreas. And here you can see the pancreatic, the superior mesenteric artery and vein going into the uncinate process of the pancreas. So meconium ileus and meconium peritonitis. What are these? Meconium ileus is a cause of intestinal obstruction from inspissated, that is very thick meconium in the terminal ileum. So this thick meconium gets blocked in the terminal ileum at the point of the ileocecal junction where the valve is there. And in most of these children, most of these infants, they have cystic fibrosis. Now we know that cystic fibrosis have children, they have a very thick mucus even in the lungs. Meconium is a sterile mixture of epithelial cells and mucosal secretion from the intestine, that is mucin and bile. Now babies with uncomplicated meconium ileus, that is no associated atresia, no volvulus, no perforation, can sometimes be managed with hyperosmolar contrast enemas to clear the meconium. That what you do is you give contrast enema through the rectum, and this will go on into the large bowel and then pass on to the ileum. And when this fluid comes in contact with the meconium, what it can do is that then it's going to make the meconium less thick and easier to pass as stool. So sometimes what happens when the meconium is blocked and there is too much of distension of the abdomen, too much of distension and stretching of the intestine, perforation can happen. Now this perforation can happen after birth or in utero. Now this is a consequence upon fetal intestinal perforation. Here we are talking about fetus. The fetus has an intestinal perforation in utero. When the baby is born with a firm, distended, discolored abdomen and signs of intestinal obstruction. An abdominal X-ray shows dilated intestinal loops and areas of calcification. Now that means it has happened long back and this meconium has now become calcified. Now occasionally the perforation has resolved and spontaneously before birth, but usually children with meconium ileus who have had a perforation will require surgery. Now abdominal wall defects, gastrochisis. Another one is exomphalus, which is divided into exomphalus major and exomphalus minor. We come to gastrochisis, which is now the most common anomaly, which is born to young mothers, those who are less than 20 years of age. Now what happened, the fetal gut, that is the stomach, the intestines, prolapses through a defect to the right of the umbilicus, and at birth the bowel is non-rotated, it is shortened and covered by a fibrinous peel. There is a defect in the abdominal wall. So after reduction of the bowel, which may need to be staged using a silo, the closure of the defect, gastrogaisis, has a good prognosis, although gut dysmotility delays recovery. So what happened? You reduce the bowel in the stomach into the abdominal cavity. Now this has to be done maybe 2 or 3 times operation, because what happened, there is deficiency of the abdominal wall, and even if you put the whole thing inside the eviscerated contents you put inside the abdominal cavity, the abdominal cavity, there is not enough room. So what you have to do is you may have to do stage procedures at specific intervals. You can take up the patient for surgery after the abdominal wall has grown. Now in the meantime, what you can do, you can use a silo. A silo is nothing but a sterile plastic or maybe a rubber sheet which is stitched onto the abdominal wall to provide a temporary cover for the bowel. Now you use a material which is not sticking, otherwise it will get adherent. It becomes adherent to the bowel and there can be perforation. Now some infants have intestinal atresia and some boys have undescended testes, but other anomalies are rare. So gastrochisis altogether has got a good prognosis, but some patients can have intestinal atresia and undescended testes, but otherwise they have to undergo stage surgery, but otherwise they recover well. Now another type of childhood abdominal wall deficiency is called exomphalus major. This is a picture of a newborn infant with gastrochisis. You can see the surgeon has in his hand the entire small intestine of the child. The stomach is also prolapsed, but we do not see any abdominal viscera like the liver or the spleen prolapsing along with the bowel. Now the bowel is not rotated here. Now you can see that white thing just close to the skin, that is the fibrinous covering. So there is not much of abdominal cavity that you can put all these things inside. So you may have to use a silo to cover them and then do repeat surgeries after specific intervals of time. So another congenital problem here, this is exomphalus. This is exomphalus major. Exomphalus minor is much smaller, where the contents are much less and they have a better prognosis than compared to this exomphalus major. Now this is a different anomaly in which the intestines and even the liver, they are eviscerated and there is a membranous sac from which the umbilical cord arises, which covers them. It may be associated with chromosomal and cardiac anomalies. Example is major. Hirschsprung's disease. Now, Hirschsprung's disease is characterized by the congenital absence of intramural ganglion cells. So the problem is called aganglionosis because there is absence of the ganglion cells in the wall of the colon and the rectum, and the presence of hypertrophic nerves in the distal large bowel. So the absence of ganglion cells is due to a failure of migration of vagal neural crest cells into the developing gut. The affected gut is in spasm, that is contraction, causing a functional bowel obstruction. So there is no mechanical obstruction here as such, like a tumor or rotation, but actually what happened, the bowel is patent, the bowel lumen is patent, except that it is in a state of spasm. So the aganglionosis is restricted to the rectum and to the sigmoid colon. In 75% of patients, that is usually a short segment, and involves the proximal colon. In 15%, that is long segment, and affects the entire colon and a portion of terminal ileum. In only 10%, that is total colonic aganglionosis. So here, the entire colon has to be removed and the small intestine has to be anastomosed to the anus in total colonic aganglionosis. But thankfully, most of the time, it is only a short segment problem confined to the rectum and the distal sigmoid colon, which means that upon resection, the descending colon can be pulled through and brought down after mobilization. The colon is mobilized and the descending colon can be brought down and anastomosed to the rectum or to the anal canal. So there is a transition zone where you have the absence and the presence of the ganglion cells that exist between the dilated. Now the dilated portion of the colon is proximal. It is a normal part it is a normal colon which contains the ganglions, and it's normally innervated. It also has normal nerve supply and the narrow distal aganglionic segment. So there is a transition zone in between. Hirschsprung's disease may be familial or associated with Down syndrome or other genetic disorders. So when you suspect Hirschsprung syndrome, you may very well look for tests for Down syndrome, and for that matter, not only for the patient, but look for other members of the family if they have this problem. Now, gene mutations have been identified on chromosome 10 and chromosome 13, which is seen to be involving the RET proto-oncogene. Hirschsprung's disease typically presents in the neonatal period, that means immediately after birth, and there is delayed passage of meconium, abdominal distension, and bilious vomiting. Now, your patient has got bilious vomiting because why? The problem is much more distal in the large bowel. It may not be diagnosed until later in childhood or even in adult life when it manifests as a severe chronic constipation. So because of this constipation, and there is chance that the entire bowel will undergo some kind of inflammation, the small bowel as well as the colon, because of the presence of stool which is not passed for a long time. It is called as enterocolitis. It is a potentially fatal complication of the disease, the inflammation of the colon as well as the terminal small bowel. So here you can see an enema which was passed from the rectum, a contrast enema which is passed from the rectum, and this contrast is very well delineated. It is passing from the rectum into the sigmoid colon, and you can see that it is passing beyond that strictured point, and you can see the proximal bowel is very much dilated, and you can see that point of the stricture, that is a transition zone. Now, barium enema in an infant showing a transition zone in the proximal sigmoid colon between the dilated proximal normal innervated bowel and the contracted aganglionic rectum. So you can see that the rectum is very much contracted, and the rectum is very much contracted, although it has a wider diameter than the sigmoid colon. You can see the rectum has very much contracted because of the aganglionosis, that is the absence of the ganglionic cells. So the diagnosis requires, what we do is, well, this is not enough. If you just do this, strongly suggests this barium enema or a contrast enema study strongly suggests Hirschsprung's disease, but to clinch the diagnosis, we need a histopathological study. So what happened is, here a good deep tissue biopsy, is taken from the rectum and the sigmoid colon via sigmoidoscopy, and perform an adequate rectal biopsy, and the pathologist has to be experienced. Pathologist it is ideal if it is a person who has seen some of these cases before to identify the absence of the ganglion cells and also the hypertrophied nerves. So a contrast enema, like we have just shown, may show the narrow aganglionic segment like in the rectum and a cone and the dilated proximal bowel. This can only suggest, but if to prove the diagnosis, we need a histological specimen. Now surgery aims to remove we have to remove the aganglionic segment and pull through the ganglionic segment to the anus. So what happened, probably the part of the sigmoid colon which is normal, or maybe the descending colon, that is pulled down and it's anastomosed to the anal canal. Now some procedures are there for treatment of this is called a Swenson, Duhamel, Suave and transanal procedures, the scope of which is beyond the details of these procedures of which are beyond the scope of this class. Anyway, it'll do you well if you can just remember Swenson, Duhamel, Suave and some transanal procedures which are done to correct this problem and remove the aganglionic segment. These can be done in a single stage or in several stages interrupted after establishing a proximal stoma in normally innervated bowel. So what happened here, because the patient has got severe chronic constipation, before you undertake the patient for surgery, you may well perform a proximal colostomy, probably a proximal colostomy in the transverse colon. The patient will be passing stool through the transverse colon, and what you can do is, when you can take up this patient for surgery, then at that time the proximal colostomy can be closed. Now most patients achieve a good bowel control, but significant minority experiences residual constipation and or fecal incontinence or further enterocolitis. Now most of the patients, they have good bowel control after operation, but some patients where the disease is affecting even lower down a significant portion of the colon or the rectum, they can still have constipation or even enterocolitis. So now coming to anorectal formations, the anus is either imperforate, that is, there is no anal canal, there is no opening, or it is replaced by a fistula. Now when you say a fistula, it means a connection between two cavities which does not pass through the muscle complex, does not open into the normal area where the anus is through the muscle complex, but it opens away from the specialized skin which represents the true anal site. So this fistula can open anywhere in the perineum, and the sacrum and the genitourinary tract are often abnormal. Now in boys, there may be a rectoperineal fistula, that is, there is a fistula, there is an opening in the perineum, and this opening is nothing but a fistula's connection between the perineal skin and the rectum. But the most common anomaly is an imperforate anus, usually no fistula, there is no anus at all, with a rectobulbar urethral fistula. So there is no anal opening, but what happened is there is a communication of the rectum with the bulbar urethra. So in this case, what happens, both feces as well as urine comes through the urethra. So in girls, the most common anomalies are a fistula opening in the posterior vestibule behind the vagina or on the perineum. Cloacal malformations, like in other lower vertebrates, where there is a common channel for passage of urine and as well as feces, can be seen, in which the rectum and the genitourinary tract share a common outflow channel. This is also more commonly seen in girls. Now here you can see the picture of a male child on the left side of the screen. There is no anal opening at all. You can see the penis, the scrotum is well developed, the rugosity on the scrotum is well developed, the testes are descended, they are within the scrotum. Now, but there is no anal opening. The true anal site is represented by a tag of tissue. Now what happened, when you do a dye study, you pass a dye through the urethra, you can see that the front one, on the other side you can see the front larger white delineated structure, that is the urinary bladder, and behind it is the rectum. So which means there is a fistulous connection between the genitourinary tract along with the rectum. So here in this case the connection is the bulbar urethra. The bulbar part of the urethra has a fistulous connection with the rectum. That's why it is important to delineate these, because the operation is different. The fistula has to be closed, this has to be disconnected. So an imperforated anus is seen associated with a rectourethral fistula, visible on contrast study performed by a sigmoid colostomy This patient has had a sigmoid colostomy. Since there is no anal opening, a sigmoid colostomy has been performed so that the patient can pass stool. Now through this colostomy, a dye has been introduced, and this through the sigmoid colostomy, the dye has gone into the rest of the colon and into the rest of the rectum, and from there it has gone through the fistula's connection into the bladder. Now the bladder is filled with contrast via the fistula and the radio-opaque dot. You can see a small dot which is placed on the skin, that is placed on the side where the anal opening should have been there, the normal area of the anal opening. So has been placed on the infant's perineum over the normal side of the anus. So here you have on the front, that is the bladder, the hugely distended, smooth opacity is the bladder, and the other one behind, that is the rectum. So most low malformations are treated by anoplasty soon after birth. Higher, more complex defects need a temporary colostomy and detailed investigation, and then is required for reconstructive surgery, because you have to disconnect any fistula connection between the rectum and the genitourinary tract. Functional outcome is related to the type of the malformation. Low defects are associated with constipation. Higher defects are associated with fecal incontinence and the integrity of the sacrum and pelvic muscles. However, low defects, they do much well than the higher defects. For children with residual intractable fecal incontinence, antegrade colonic enemas administered by a catheterizable appendicostomy, the Malone or appendicostomy colonic enema procedure, enable the child to achieve a social continence. Now some patients who have got fecal incontinence, not able to pass stool, so antegrade colonic enemas can be given. Now let me show you the picture. You can see there is the cecum and you can see the appendix. Now through the appendix, it's called an appendicostomy. That is, you can connect a tube where enema fluid is being infused through that tube, and then what it can do is it will cause some kind of provoke bowel movement, and the patient will be able to pass stool. So this is appendicostomy for delivery of antegrade colonic enemas. So we have come to an end with most of the topics of pediatric surgery that commonly seen once we are dealt with. So I will close the topic here. Common pediatric surgical conditions, we have covered most of them. And if you have any doubt about any other section, anything you have missed out or not understand, then you can feel free to contact me, and we will do a revision class on any particular topic that you like. Thank you.